And we will continue to the second talk today that is going to be given by Dr. Ryan Tedford from Johns Hopkins. Ryan is a heart failure doctor that his clinical passion is LVAD and heart transplantation, but his research is focusing on the right side of the heart together with the pulmonary hypertension. His talk is going to be about mechanical support for right-sided and biventricular failure. So Ryan?
Nir, Naveen, Bill, and the entire ACURE working group, many thanks for the invitation to speak. So we know that the RV is acutely afterload sensitive, but even patients with chronic RV failure do respond to reductions in afterload. I think this is really well illustrated by this study in patients with severe RV failure due to idiopathic pulmonary arterial hypertension who ultimately underwent lung transplantation. What you can see here is there's really an inverse relationship between mean pulmonary artery pressure as that declines after transplantation and RV ejection fraction. All these patients with severe RV failure all had ascites normalize this right ventricular ejection fraction by 3 months. There was also evidence of right ventricular remodeling with RV size, reduction in the tricuspid valve annulus size, and tricuspid regurgitation. But it turns out the lung transplant population actually is very different from a population of mechanical circulatory support patients. This is a study by Amesh Reina and Paul Forfia where they looked at different contractile patterns in 4 different groups. We have a normal group, we have a patient undergoing a heart transplant, bypass surgery, and then the lung transplantation patients. And they looked at the changes in contractile patterns, and they looked specifically at the TAPSE to right ventricular fractional area change ratio. And what you'll notice here is that compared with the normals, the heart transplant patients and the CABG patients both experience a decrement in longitudinal function, whereas the lung transplantation patients actually had that longitudinal motion preserved. And the authors theorized here is actually the loss of pericardial constraint that may have contributed to why the lung transplant patients maintained their longitudinal shortening. And it turns out that especially in high afterload states, the RV is very dependent on longitudinal shortening for most of its function. The free wall, which is transverse shortening, can make up for that, as it did in this study, as long as the afterload is very low. But in higher load states, it is unable to do so. So we want to investigate this a bit more in LVAD patients to see what happens. And the first, at the top of this slide there, is data from our institution, 45 patients. Now, this is not all comers. These are patients who had a ventricular assist device placed, who also did not require inotropic therapy, temporary mechanical circulatory support, or pulmonary vasodilators at either of the hemodynamic measures. The second cohort is from the University of Minnesota. That's currently unpublished data, but I think the strength here is that the post-hemodynamics were done within 3 days. Now you'll notice that in both cohorts, right ventricular afterload decreases and does so early on, and that's true regardless of whether you measure afterload as PVR, pulmonary vascular compliance, or effective arterial elastance. As you would expect, wedge pressure also declines as we unload the LV, but there's really no change in right atrial pressure. And the result then is that the right atrial pressure to wedge pressure ratio dramatically increases. And so this may actually suggest that the RV is getting weaker during this implant process, even in those patients without clinically apparent right heart failure, at least if you believe the right atrial pressure to wedge ratio is a marker of RV dysfunction. And hopefully with the next slide, I will prove that to you. This is data from 2 different cohorts. On the left-hand side is data from the ESCAPE heart failure study, 144 patients who received pulmonary artery catheter-guided therapy. And I have pictured here the pre and final measures from the pulmonary artery catheter. As you would expect with treatment of heart failure, right atrial pressure declines, wedge pressure declines, and cardiac index increases about 0.5 liters per minute per meter squared. But you'll notice there's actually no change in this ratio whatsoever. And if you break that up into groups of patients who required inotropes and those who did not, also no change in this ratio, despite increased venous return to the right ventricle. This is unpublished data from Hopkins, just showing the effects of a balloon pump on patients with chronic heart failure. We actually saw a significant rise in cardiac index, about the same, 0.5 liters minute per meter squared. But again, no significant change in the right atrial pressure to wedge ratio. Now, if I just go back to this slide for a minute, you'll see that the changes in cardiac index were actually very similar to what we see in both VAD cohorts here. And so this would really suggest that the idea that increased venous return is responsible for the right heart failure we see after a VAD is probably not the whole story. And secondly, that this right atrial pressure to wedge ratio is very consistent. So we can graph this, and the black line here is the right atrial pressure to wedge ratio, and you can see that certainly it is going up between the pre and post VAD despite markers of load decreasing. But then over time it begins to improve again, but it appears to do so as load continues to decline. And we can graph this by comparing the total load here measured as effective arterial elastance to either the right atrial pressure or the right atrial pressure to wedge ratio. And you can see there's a dramatic difference between this relationship pre-VAD and post-VAD. In post-VAD, there's a very steep relationship between right atrial pressure and the load that's imposed against the right ventricle. And so in totality, this suggests that the RV is getting weaker during the VAD implantation, and very small changes in load after a VAD implantation really dramatically impact right ventricular function. And therefore, but despite that, load is declining early, but will continue to do so over time. And that would then suggest that tincture of time and support while load continues to decline may be enough to get your patient through when they're experiencing right heart failure. So when, despite optimal medical therapy, we are still failing, we reach for our mechanical circulatory support devices. And on the right side, there's two main questions. Do we put the RVAD in at the time of implant in our high-risk patient, or can it be delayed into those who only show us that they need it? Or do we need to use a permanent device or a temporary device? Probably the study that's the most highly quoted is a study from the group from Penn. They looked retrospectively at 99 patients who required biventricular support, and as in all of these case series, you would see those who required a right ventricular assist device had a worse outcome. And in this study, those who receive an upfront right ventricular assist device did better than those with a delayed Bi-VAD. Now, this is an older cohort of patients. Older, I mean a non-contemporary cohort. All of these were older devices. But nonetheless, this suggested the benefit of a primary RVAD in patients at high risk of right ventricular failure. Now, this is a little bit different from the Asawi study, who now we're getting into a little bit more contemporary cohort of mechanical assist devices. At least on the LVAD side, about half of those were continuous flow devices, and only temporary RVADs were used in this analysis. You'll see, one, that the overall mortality remains very high, 53%, but at least in this retrospective study, there was no difference between the early and delayed approach. The Lefort study, I think, is probably the most representative of a contemporary cohort. The LVADs used in this study were almost all continuous flow devices, and all the right-sided support were via a centrifugal Centromag device. So the first question they asked is, when they retrospectively looked at these patients, if you had an LVAD and a temporary RVAD, how did that compare to patients who received biventricular support, more durable, or total artificial heart? You can see that the patients receiving that Bi-VAD or total artificial heart had a higher 30-day mortality than those with an LVAD plus a temporary RVAD. Now, certainly you could say, well, that's just a sicker patient population, and that may be true, but at least retrospectively, there was no difference in perioperative RV risk scores, demographics, or hemodynamics. They also wanted to look at this question of primary versus delayed, and in this cohort, even though the numbers were small, they again saw a signal that if you waited till the patient really declared they were in cardiogenic shock and required an RVAD, that their mortality was worse. So I think probably the most intriguing study, and the authors of this study are in the room, comes from the Recover Right study, and you've heard a little bit about that today, but I just want to point out a couple of things. Of these 30 patients, 18 were patients who had LVAD and subsequent RV failure. And as you would expect when this Impella RP device is placed, you had an increase in cardiac index and an increase in a decrease in central venous pressure. But I think what's most remarkable, after a mean duration support of just 3 days, when these were weaned off, they were actually able to maintain this increased cardiac index and also maintain a lower CVP, suggesting that this short-term support was actually enough to get the RV compensated again. The other thing that I'll point out here is, although certainly this study was not powered for mortality, it's actually much less than what we've seen in the other case series, with a survival around 80%. So to summarize, RV adaption to load worsens after LVAD implantation, yielding the RV increasingly afterload sensitive, and it may be that an afterload with PVR of 3 is actually too much for the RV that's struggling. I think there is mixed data on primary versus delayed support, but I think in totality, an earlier primary approach likely is the best for the patient. And then in most cases, in the setting of contemporary LVAD devices, temporary RV support, and optimization of load in the interim period may be sufficient to get your patient through. Thanks very much for your time.
Ryan, thank you very, very much for a fascinating talk. And until I see Herman coming to the microphone, I will ask you a question before that. There is a difference in how acute LVAD is unloading the left ventricle and how chronic LVAD is unloading the ventricle. There is a difference between HeartMate 2, that is an axial flow pump that is sitting in the belly, to HVAD that is sitting in the chest, and how they affect the septum. And maybe actually it's not as you said, it's not the flow to the RV, it's rather the shape that the RV is getting when you move the septum. How do you see it in here? How do you think it's going to affect early or late when you choose different type of devices?
Yeah, so I think it's a great question. You know, one of the things that we know that the right ventricle is really dependent on left ventricular function for a lot of its function. And I think the idea that we need to really separate acute heart failure and an acute exacerbation of chronic heart failure is in fact very important, because I think they are very different, as are the devices that we use. You know, the LV twist is actually a very important component of both LV function and RV function. And when we put a device that's extrapericardial, that may impact the twist, as does actually interruption of the pericardium itself. So I think these are all things that we need to sort out better. I don't have an answer necessarily. I don't think we have enough data right now to support that there's absolute differences between the two devices, although I'm sure that's on its way. But an important concept to be aware of.
Herman?
I wanted to come back to your comment which you made on leaving the pericardium intact, like in lung transplants, that's the case. You know, for the LVAD implantation, we also seem to see a difference whether we do it through a sternotomy, which means opening the pericardium and doing what's called minimal invasive implantation of the LVAD. It's not so much actually minimal invasive, it's more sternal sparing. So we use a transapical incision for the HVAD system, and then an anterolateral thoracotomy for the outflow tract. And although you need sometimes temporary RV support, one has the impression that the RV function recovers much faster than after sternotomy. I just wanted to hear your thoughts on that.
Yeah, so I think that's a really interesting concept. And actually, what got me most interested in this, so we were actually comparing hemodynamics in patients who had a thoracotomy approach versus sternotomy. And although we did initially see some differences, we found that at least the group that we looked at had better hemodynamics preoperatively as well. So I think it was very difficult to sort that part out with the data set that we had. I think it's a really interesting concept. I guess I would throw it back to you and ask, you know, in animal studies, for example, the effects on LV twist and septal function appear to influence septal function really at the initial onset. Now, if you close up the pericardium, you can regain some of that function. But do you think that it's minimally invasive enough, and do you think you have an intact pericardium where you would see those results? And I don't know the answer to that question.
It's also, of course, pure speculation, but I think at least it's really, I mean, with regard to the pericardium, it's obviously a very small incision you do at the apex, and then again next to the aorta. So at the side of the right ventricle, at least the pericardium is left intact. We just published actually our series on right ventricular recovery with that kind of approach.
I look forward to looking at it.
Tal?
Thank you for an excellent talk. For me, this issue of RV function is maybe the most difficult in LVAD. It's difficult because there's multiple factors. We know that the RV is very sensitive. It's even more sensitive than the LV, and we see those changes very rapidly after surgery. Even after, valve surgery, we see RV function which deteriorates and then improves. So I think we need a better definition of what is really RV dysfunction after LVAD. And this, I think, is the key issue here, and maybe I want to hear your thoughts. Specifically, we know there's kind of the correlation between RV function and volume overload. And if there's volume overload with RV function and vice versa. So how did you differentiate? Maybe in those patients, if you unload with volume, you would not need support for the RV. It will just come back to a normal function. So maybe two questions.
Yeah, so to answer your question about the issue of volume overload versus RV dysfunction, I think it can be tough to sort out. You know, there's data that goes back to the 80s, and bypass patients, you're unable to wean from cardiopulmonary bypass. And a lot of those patients had a RA pressure to wedge ratio in the 2 range, so their right atrial pressure was double the wedge pressure. And in those studies, they actually could remove fluid via the bypass machine and waited until they had a almost level right atrial pressure to wedge ratio, and then they were actually able to wean those patients off. So I think if you do have an abnormal ratio like that, it would certainly suggest that there are some volume issues and you need to try to remove that. But I think it's a tough scenario. You know, learning how to measure right ventricular function is kind of the holy grail, and all of our measures have limitations, including RV ejection fraction, and you know, certainly there's limitations. We have a lot of patients in the room who are interested in pressure volume loops on the RV side as well. The defibrillator we were talking last night actually has issues when we try to better look at that function. I think there is some emerging data in right ventricular reserve measures that may help us better define the state of the RV, at least before VAD implantation. Afterwards, they may be a little bit too sick to do that, but that may be one avenue that helps us better define the state of the right ventricle.
Thank you very much.